Orthodontics is on the threshold of a change in diagnosis and treatment planning, from the traditional emphasis on the dental and skeletal components of a problem to a greater attention to soft tissue. This change is occurring because of a paradigm shift in conceptual underpinnings of orthodontics. This increased attention to soft tissue and de-emphasis on perfection combine to form a biologically driven paradigm that will better serve orthodontics in the 21st century. It represents a philosophical 180-degree turn in the orthodontic conceptual framework.
To be effective, orthodontic treatment must address the underlying myofunctional problems causing the orthodontic disorder. As far back as 1907, Edward Angle published research showing that crowded teeth and jaw discrepancies are not hereditary, but are caused by the way a child swallows and breathes.
The influence of the lips in modifying the form of the dental arches is an interesting study, and almost every case of malocclusion offers some noticeable and varying manifestation of it.
Consider the consistency of this view 100 years later.
In cases of malocclusion, strikingly characteristic abnormalities in lip function are often noticeable, leading to the suspicion that more often than is recognized, the peculiarities of lip function may have been the cause of forcing the teeth into the malpositions they occupy.
Of course, Graeber was one of those pointing this out back in the 1960s.
It is imperative that the orthodontist appraise muscle activity and that he conducts his orthodontic therapy in such a manner that the finished result reflects a balance between the structural changes obtained and the functional forces acting on the teeth and investing tissues at that time.
Look at this child. He is a mouth breather. There is hyperactivity of the oral musculature, a tongue thrust. Look at the arch form. It's not surprising he has an open bite and crowding. Same again. Lots of muscular activity and the resultant malocclusion. Again, that overactive mentalis. Not surprisingly, the lower arch form is completely flattened. There is no space for the canines. This is not crowding. This is the myofunctional effect on facial growth and the dentition.
A normal upper arch should look like this. It forms that way because the tongue rests in the area between the upper teeth. There it counteracts the pressure of the cheeks, which would otherwise push the upper arch of the jaws in. But if a child sucks his thumb or breathes through his or her mouth for any reason, then the tongue drops from the top of the mouth and the upper arch can get pushed in.
Look at this chronic mouth breather. The underdeveloped maxilla, the open bite because the tongue has nowhere else to go. Do you think facial growth is being severely compromised? Orthodontics will not correct this, and unless the myofunctional problems are addressed, the abnormal facial development will go on unchecked. This is why it is so important that we provide patients and parents with suitable treatment. And the time to treat developing malocclusion is while the children are young, well before orthodontic treatment is suitable. We can establish this by understanding what causes malocclusion: big teeth, small jaws, or poor function. Consider the research on forces exerted on the teeth by the lips and the tongue. We only need 1.7 grams of lip pressure to move teeth. But in fact, the lip exerts a force of between 100 and 300 grams. In addition, the tongue exerts a force of 500 grams against the anterior teeth. So clearly, the function of the lips and tongue will determine tooth position. Orthodontic techniques are designed for teeth, not muscles. A totally mechanical approach to a biological problem. Muscles are a significant factor in causing the malocclusion and should not be overlooked in any effective treatment approach. To understand the myofunctional issue, we need to establish what normal function is. Here's Alex at 3 years of age. breathing through the nose while sleeping, which supports natural craniofacial development, the correct arch, shape and form. Now here's Alex at 5 years of age. Note the good occlusion and plenty of space for the permanent teeth.
I'm Alex and I'm 11 years old. I breathe through my nose and my tongue position is correct. And when I swallow, you can't see my lips move. Guess what? I have perfectly straight teeth and properly developed jaws. See how wide my top jaw is? That's normal.
You rarely see this correct arch form and correct dental alignment. However, this is what you want to achieve after treatment. Incorrect arch form is responsible for the high prevalence of malocclusion. But the arch form, as we've seen, is primarily a product of the position of the tongue and the function of the lip. Correction of this dysfunction would seem necessary for successful, stable treatment. As Graeber says, treating developing malocclusion early by addressing myofunctional problems also helps limit the potential for orthodontic procedures to be unstable and for relapse. Little's research in 1988 demonstrated that only 10% of cases were judged to have clinically acceptable mandibular alignment at the last stage of diagnostic records. He concluded that the only way to ensure continued satisfactory alignment post-retention is the use of fixed or removable retention for life. The University of Cologne conducted a study in 1964 of expansion and relapse in 500 patients. They concluded, contrary to widely held belief, that prolonged retention periods do not prevent relapses. Nanda and Nanda asked,
Does contemporary orthodontics have no satisfactory solution to the problem of achieving long-term stability? Perhaps several additional factors may have an important bearing on orthodontic stability.
Increasingly, we are realizing that long-term stability is not the norm and that we do need to treat these additional factors. Here's another, even more recent statement from the American Journal of Orthodontics.
My observation over the years has been that change is the only constant factor, and that to expect complete long-term stability is not possible. Muscle factors, tongue position, and function all play a great part and can lead to eventual change or recurrence of the original problems.
Chris Farrell and the International Myofunctional Research Company are committed to the prevention and treatment of malocclusion through non-intrusive retraining of the oral musculature and the elimination of bad oral habits. Through the past decade, they have designed, developed, and manufactured a range of innovative and highly effective dental appliances. For more than 2 decades, Dr. Farrell, like Engel and Graeber, has focused his professional attention on the 3 M's: muscle, malformation, and malocclusion. The trainer system has helped thousands of children and their parents in Europe, the USA, Asia, and Australia. The trainer system includes the Pre-Orthodontic Trainer, Trainer for Braces, and the Trainer for Finishing.
These appliances are based on nearly 100 years of research into myofunctional aspects of malocclusion and facial growth. Much of this research by eminent authorities has been ignored in current orthodontic techniques. Look at all the research on mouth breathing. There's now considerable research evidence from Harvard in the 60s to now with Woodside, Lyndon Aronson, Breslin and Shapiro to Peter Vig, showing that mouth breathing and open mouth posture is detrimental to craniofacial growth. Furthermore, studies show that correction of this habit leads to favorable improvement of horizontal craniofacial growth. The Pre-Orthodontic Trainer has been specifically designed to correct these myofunctional habits and also to assist the alignment of the erupting teeth in the mixed dentition stage. Here's Michaela, 13 months of trainer use has changed her mode of breathing and overactive mentalis. The result is improved growth direction and positive dental changes. Note also passive arch expansion achieved by correcting the tongue position. I designed the trainer appliances to treat the myofunctional causes of malocclusion as well as to align the teeth. To do this, we harnessed the knowledge of myofunctional research and computer-aided design technology. In fact, we were the first to use computer-aided design technology to develop intra-oral appliances. This breakthrough meant that we were able to design and produce universal-size intra-oral appliances with therapeutic characteristics that could retrain the oral musculature and improve function. The Pre-Orthodontic Trainer for myofunctional habit correction in the mixed dentition stage makes every future orthodontic treatment easier and prevents aberrant facial development, which is, of course, difficult to treat as the child gets older.
This is the Trainer for Kids, or T4k, get it? The Trainer for Kids is designed for kids my age and younger before orthodontic treatment. It helps correct the cause of tooth and jaw development problems. You use the blue or green one first. I prefer blue. It's quite soft and very flexible, so it can adapt to your mouth. Then, after 6 to 8 months, you use a harder one. These are pink or red, and boys prefer the red one. If you have to go into braces, you can use a different trainer specially designed for that, the Trainer for Braces, or T4B. The idea of these trainers is that they correct the muscles as well as the teeth, and they train you to breathe through your nose as you should.
The trainer has several key features. It's a tooth positioner.
The tooth channels and labial bows impart a constant force on the anterior teeth when it's in place to encourage their correct positioning. The child will notice a light force on the teeth as soon as it's put in place.
It's a myofunctional trainer.
Tongue position and incorrect swallow is a major cause of orthodontic problems. The trainer has a tongue tag for the proprioceptive positioning of the tongue tip. The tongue guard prevents a tongue thrust swallow when in place, a training process for the tongue. Lip bumpers or mentalis stretchers to stretch and deactivate mentalis contraction associated with a tongue thrust swallow.
It's a jaw positioner.
Class 1 edge-to-edge bite is achieved, the same as in many functional appliances. It is used for pre-orthodontic correction of mode of breathing and mandibular position. The double mouth guard forces the child to breathe through the nose, a training process to change the mode of breathing and to correct mouth open posture, which is so detrimental to horizontal mandibular growth. The T4k program starts with a soft blue or green trainer. The soft material makes compliance easier. It's easy to wear and the child gets into myofunctional treatment. But at this stage, the tooth positioning force is minimal. The soft trainer should be worn a minimum of 1 hour per day and overnight for about 6 months. It may fall out at night at first, but if patients persevere with the program, it will eventually stay in. Soft trainers have holes to allow for some mouth breathing, but the child should try to keep the lips over the holes. After about 6 to 8 months, the child progresses to the hard trainer. It's the same design but is made from much stiffer material to apply more force on the anterior teeth to start bringing them into alignment. It's the same principle as orthodontic arch wire. Clenching also helps to increase the alignment force. The same myofunctional and jaw positioning is present in the hard trainer. Children with less severe malocclusion and functional problems can go straight onto the hard trainer.
The pre-orthodontic trainer is used to correct myofunctional habits prior to orthodontic treatment. When the patient progresses to fixed braces, they use the trainer for braces.
The T4B reduces soft tissue trauma, corrects myofunctional habits, assists Class 2 correction, and treats TMJ symptoms during orthodontic treatment. It reduces treatment time and improves stability. It has the same design characteristics of the T4k, but also has channels to cover the brackets and is longer to accommodate the second molars.
Cases that are nearly ready for braces and have myofunctional causes can go straight to the T4B and continue with the same appliance once the brackets are on. It's a useful bit of pre-treatment preparation before the brackets. The T4k is for the mixed dentition and the T4B for the patient in fixed appliances. So, what about arch development? In another part of the Harvard research on primates, they fixed acrylic blocks in the palates of monkeys. They found that these cause malocclusion. So arch development with acrylic appliances like this will make the problem worse.
This is Alex again. This is Danielle. I'm wearing a clock symbol and I can't talk properly. I'm wearing a sagittal and I can't swallow properly.
We've developed a more effective alternative, the farell bent wire system.
Designed for use in conjunction with the trainer system, the farell bent wire system is used for improving arch development while simultaneously treating myofunctional habits. More information is available in the farell bent wire system video and manual and the continuing education courses.
At the end of treatment, when the teeth are in good position but myofunctional habits may still be a problem, we have the trainer for finishing. The T4F is my newest appliance using new semi-moldable technology. The inner part is like the hard trainer material and is covered by a thermoplastic material that softens and molds in hot water. The inner part does not soften but is adjusted to arch size like the red T4k. It's the same trainer design with the tongue tag, the lip bumper and the Class 1 position, but it's customized for the patient's mouth and fits tightly in the upper arch.
This customized remoldable appliance used after orthodontic treatment is 3 appliances in 1. It's an immediate retainer, a myofunctional trainer, and an active positioner. It requires minimal chair time.
The T4F can also be used as an orthopedic appliance in a similar way to the use of a bionator or a Clark twin block before fixed appliances. So before, during and after orthodontic treatment, you can treat myofunctional habits as well as dental alignment. There's more information in the manual or on our website. Myofunctional problems should be addressed as soon as they are evident, from as early as the age of 5 or 6. Particularly with facial growth, the earlier we start, the easier it is to make these corrections. Just about every